Okay, good morning everybody. I would like to thank Professor Tiwari for this opportunity. Professor Tiwari is a teacher to most of the RPC students and retina specialists. So when to operate depends on the etiology of the hemorrhage. Vascular etiology is implied if the patient is diabetic, hypertensive, or has features to suggest ocular ischemia syndrome, such as if he has had cerebrovascular accidents or has a positive findings on carotid Doppler. This is if you cannot see the fundus. If you can see the fundus and see the vein occlusion or the retinopathy, then it's anyway obvious. This is to show that even without any features of diabetic retinopathy or vein occlusion, we can have hemorrhages. If it's a vascular cause, then you plan for early surgery if there is no history of any treatment given to the patient. No laser has been given, because such a patient would be at risk for developing ischemia or neovascularization of the iris. Or if the patient has not received anti-VEGF and is not willing for anti-VEGF, or anti-VEGF is not available to the surgeon. In these cases, relatively early surgery should be planned than if the patient has had these treatments. In a patient, as Dr. Tinku Bali had mentioned, if there is a risk of retinal detachment, then you would be more alert and would probably plan for surgery earlier to prevent a retinal detachment. This happens if the patient gives a history of flashes before the hemorrhage, or there has been a severe blunt injury, or there is a family history of detachment, or the fellow eye has had a detachment, or the patient is a high myope and has developed a hemorrhage. So in these cases, the risk that the patient will develop a detachment from an underlying break which is not being seen because of the hemorrhage is there. So if you don't operate, then at least you are alert and you see the patient frequently. For example, this was a patient who had a hemorrhage and was complaining of flashes in that same period. And when you saw carefully, there was a large tear, which after a few days, as the hemorrhage cleared, could be treated with laser demarcation. And otherwise, if you are not alert, you may have a situation like this. The blood has cleared, but the retina is also detached from a tear, or a large tear here. There may even be a giant retinal tear following a blunt injury. So you have to be alert and maybe operate early. One of the features it helps to decide is whether the blood is organized. If it is whitish, it is organized and is not likely to clear on its own. So such a patient, even at presentation, you have to advise surgery. Whereas if it is a red blood, there is a chance that it absorbs on its own. If you see a patient with neovascularization of the iris in a vascular etiology, hemorrhage, then it depends on whether the neovascularization is is fine or mild to moderate and the angle is open. Then you can attempt to salvage the eye by giving an anti-VEGF agent, which creates immediate, relieves the ischemia immediately, and then go in for vitrectomy and do a good pan-retinal laser on the table, and you may be able to salvage an eye like this. But if it's very florid NVI, the angle is closed, and you have vitreous hemorrhage, then it's better to leave it. Other things that decide when to do surgery is density of hemorrhage. I think this was also covered in the morning by one of the speakers. If you see a lot of treatable retina, then you can just treat the retina and observe, provided there is no traction near the macula. For example, this was a patient who came with hemorrhage, but in the periphery you have a lot of areas which can be treated, so you can observe. Also, if the patient has had a lot of laser in the past, you see extensive laser scarring. This is a patient who is not at risk for developing complications like neovascularization of the iris or even repeated hemorrhages are unlikely because of the extensive scars. So you can observe such a patient and supplement your laser as the blood clears. Similarly, if you have a lasered patient who is bleeding because of new vessels on the disc, florid new vessels or somewhere else, new vessels, you can just inject an anti-VEGF so that the new vessels regress for 2-3 months, and you have a time when the hemorrhage clears, you can complete the laser. This patient does not need vitrectomy to complete the treatment. The other things that you want to see is any proliferation. If you see any fibrovascular proliferation like this, then you want to go in soon to prevent complications. This is a patient who presented like this, and within 5 days, as we were waiting for clearance, this was the condition, the RD had progressed to the macula. Finally, he did well, but this is to say that any fibrovascular proliferation needs intervention. However, if the proliferation is on the periphery, like in the picture on your left, then possibly you can observe, but if it is involving the macula, then you want to operate. Or if it has become a combined, meaning that the traction has led to a tear, and then that has led to a rhegmatogenous component, this needs to be operated and urgently. This will not settle on its own. If you have a retinoschisis as a cause for hemorrhage, that can be observed without any surgery. And then B-scan also always guides you whether you need to intervene soon or not. If you have a traction, especially near the macula like this, you have to operate. These cases need surgery urgently. May not be urgent in terms of days, but at least in weeks. But if you have a rhegmatogenous retinal detachment underlying a hemorrhage, as seen on the B-scan like this, then this is urgent. This is in days. Or if you have a good PVD with, as in this case, a complete PVD, then you know that you can operate because the surgery will be more simpler and with less complications. If you have a complete PVD, then this is a good surgery. On B-scan, you decide to defer surgery. If there is no PVD, not that this is a major contraindication, but certainly you would like to see PVD, so you could wait. Or if you have choroidals and with vitreous hemorrhage, then there's no point doing a vitrectomy here. Or a very old RD which is fixed, non-mobile. But as has been mentioned earlier, you continue to observe the patient even if you don't operate. And the other thing to do regarding timing of surgery is, if possible, try to stop the antiplatelet agents, especially in vascular etiology hemorrhages, because the bleeding will be much more per-operatively and post-operatively. If possible, stop the anticoagulants, and also try to schedule a dialysis 12 hours before the surgery, because it improves the post-operative healing. If you have normal renal parameters, the risk of infection is lower. But you have to have it 12 hours before surgery because you need time for heparin elimination.